over to Dr. Aswathy for speaking on pathologic myopia, the current understanding.
Good morning all. My topic today is pathological myopia. So what is pathological myopia? Often we use it interchangeably with the term high myopia, but high myopia is just something with refractive error more than 6 diopters. Pathological myopia is that type of myopia which is accompanied by degenerative changes occurring especially in the posterior pole. A lot of confusion existed as to what to include and what not to include in pathological myopia, but a group of researchers in myopia recently came up with a classification that's known as meta-PM classification. According to that, PM is defined as eyes having chorioretinal atrophy equal to or more severe than diffuse atrophy, or the presence of plus signs, or as eyes having posterior staphylomas. So how much are we burdened by this disease? According to various meta-analysis, in 2015, around 10 million people are visually impaired from myopia, of which 3.3 million are blind. And it's projected that by 2050, around 55.7 million people will be visually impaired from myopia, of which 18.5 million will be blind. So the prevalence of myopic visual impairment is gradually rising from 0.1% in 2000 to 0.6% in 2050. And it is 2 to 4 times almost higher in Asian population as compared to Europeans. What are the risk factors for pathological myopia? These include older age, worse myopic refractive error, longer axial length, and presence of fundus tessellations. So posterior staphyloma is the hallmark of myopic pathological myopia, and that itself can lead to most of the other retinal changes and cathoidal. The pathogenesis has been dealt in detail by Dr. Samyukta, and it's basically the axial elongation causing chorioretinal stretching and various changes in the collagen. Posterior staphyloma, as described by Richard Spade, is an outpouching of the circumscribed region of the posterior pole of the eye that has radius of curvature shorter than the radius of curvature of the adjacent eye wall. Now it is independent of the axial length. Actually, it can occur even in people with normal axial length. Curtin's classification was the most commonly used classification for myopia, but recently a more simplified classification called TDMU classification has been proposed by Ono Matsui. According to that, we have mild macular, narrow macular, peripapillary, nasal, and inferior staphyloma. How do you identify a posterior staphyloma? We have wide field fundus photograph on which we can see the pigmentary alterations at the margin of the staphyloma. 3D MRI shows the outpouching in the posterior pole, and there is an ultra wide field OCT in which there is an inward bending at the region of the margin of the staphyloma, and at that region you also notice a choroidal thinning. On either sides there is thickening of the choroid, but at the margin of the staphyloma there is thinning. Diffuse chorioretinal atrophy can be either peripapillary or macular, and peripapillary is the first one to develop. Here there will be a segmental and abrupt thinning of the choroid in the temporal peripapillary region, and the choroidal thickness of less than 60 microns, about 2500 microns nasal to fovea, is diagnostic or 100% specific for peripapillary diffuse atrophy. Now identifying this in children is very important because that is an indicator for eventual pathological myopia or posterior staphyloma in adulthood. Macular diffuse atrophy is often difficult to diagnose, especially in less pigmented fundi, and there will be marked thinning of the choroid in the area of diffuse atrophy. The subfoveal choroidal thickness will often be less than 100 microns. Patchy chorioretinal atrophy rarely affects the central fovea. It can be derived from either lacquer cracks or diffuse atrophy. When they are derived from lacquer cracks, it's almost longitudinal, and when derived from diffuse atrophy, it's almost circular. When you do autofluorescence, you get a uniform hypoautofluorescence at the region. Loss of RP with or without Brooks membrane defect will be seen in an OCT, and in an FFA there will be hypofluorescence in the early phase with hyperfluorescence along the edge in the late phases. Myopic macular neovascularization is smaller, less active, and more difficult to detect due to background chorioretinal atrophy, and the exudative changes will be much lesser as compared to ARMD related CNVM. It can occur in 3 phases: active, scar, or atrophy. The active stage is identified by small grayish membrane in the subfovea or parafovea, and when you take an OCT, you can see a highly reflective area above the RP layer with significant exudative changes, although that would be less than that seen in ARMD related CNVM. In the scar stage, there will be a fibrous scar covered by proliferated RP cells, and this is known as the Fuchs spots. And in the MNV will be enclosed by the RPs in a bright line and OCT. In the atrophic stage, there will be well-defined whitish or slightly pigmented choroidal atrophy. And in the OCT, there will be subretinal elevation with increased penetration of light at the site, and Bruch's membrane will be all tattered and fragmentary. OCT is very useful here because it shows a clear vascular network is at all stages of MNV, and a shrinkage will be noted following treatment with anti-VEGF. And this is especially useful in differentiating it from a simple macular hemorrhage. Fluorescent angiography shows hyperfluorescence in the active phase with dye leakage, but in the scar phase there won't be any dye leakage. A lot of clinical trials like Repair, Radiance and Mirror have demonstrated the effectiveness and safety of ranibizumab and aflibercept in MNV. But unlike in ARMD, a single injection of VEGF followed by PRN treatment will suffice. Lacquer cracks represent healed and mechanical breaks of RP, Bruch's and choriocapillary complex. And in the OCT, it is seen as discontinuities of the RP with its increased penetration of light through the choroid. In autofluorescent will be hypoautofluorescence and hyperfluorescence in an FFA, and OCTA shows a partial defect in choriocapillaries at the site. Simple macular hemorrhage is important because that will herald the new lacquer formation, lacquer crack formation, and in the FFA and autofluorescence there won't be any hyperfluorescence. Differentiated from CNVM. Myopic stretch lines are often another finding. You can see large choroidal vessels that often project into the retina. Radial tracts are also another finding that is seen in pathological myopia, but unlike those seen in CSCR, these are directed upwards from the margin of the staphyloма. In CSCR, they are seen as descending tracts. Autofluorescence is very good in identifying the patterns of radial tracts. And in a large population of those with myopia, there is a peripheral avascular zone, and macular vortex veins are also very common in those with pathological myopia. Myopic tractional maculopathy is one of the most common causes of loss of vision, and it is caused by outward tractional force balanced by inward tractional force of the posterior sternum. There are a lot of classification things, and retinoschisis is the separation of the retinal layers. It can be inner or outer. Outer is more common, and that can lead to even a foveal detachment. And unlike the idiopathic macular hole, the lamella hole will lead to detachment in case of myopia. And when that happens, you can go for a pars plana vitrectomy with ILM peeling and intraocular gas tamponade, and often inverted ILM flap and autologous retinal free flap are effective for better surgical closure. Dome-shaped macula is another finding here. There is more than 50 microns of macular bulge, and you can almost in nearly all cases you can see some SRF, but that doesn't require any treatment. Optic disc anomalies are in plenty, and that makes it difficult to diagnose a case of glaucoma in case of myopia. Intrachoroidal cavitation, you can see there inside the close to the peripapillary region. And optic disc pit and conus pit are also very common, where you see a significant retinal thinning or often absence of full thickness defect of sclera. And there is a lot more, but I am rushing through. Thank you.
Thank you very much, Aswathy, for that.